some indispensable clues for suspecting leukemia. It's important to look at all parameters. We just see HB, WBC, platelet and get done with it, but no. So if there is a bicytopenia or there's an elevated WBC count with the other two cell lines being low, that's again a very red flag sign. A normal or high MCV in the setting of a low hemoglobin with a normal vitamin B12 is a very big. So we have seen this in many, many children. They come to you with anemia only. All other cell lines will be normal. And it will be a normocytic anemia. So in children, we expect a microcytic hypochromic blood picture, but this here it will be a normocytic anemia. And that's again a very important red flag sign. Lymphocytosis without any viral infection is again worrisome. And a reticulocyte count is a very simple test to assess if the marrow is working or not. How do we actually confirm the diagnosis? By doing a bone marrow aspiration. So we see the morphology, we send for flow cytometry and cytogenetics. I'll come to what they are. Sometimes what happens, the bone marrow is completely infiltrated by the leukemic cells and you don't get a bone marrow aspirate. That time a biopsy is very, very important. It can give you a lot of information. And do not administer steroids without having a complete evaluation. Sorry. So like I said, the WBC can be high or low. Neutropenia is important to, always look at. Anemia occurs in approximately 80% of the children in diagnosis. Thrombocytopenia, approximately 75% have less than 1 lakh. But they never come with severe hemorrhage unless there is any infection around. So this is how we do the bone marrow test from the posterior superior iliac spine. In very, very younger children, we do it from the tibia, just below the tibial growth plate, just below the prominence of the tibia, the tibial tuberosity. But mostly we do it from the posterior superior iliac spine. So what do we see in the bone marrow? We look for the morphology. How are the cells looking? So this can give us a lot of clues. So this is the old FAB classification where they have divided the lymphoblast into L1, L2, L3. Which is no longer used, except that this L3 morphology with these vacuoles are a telltale sign of a Burkitt's leukemia or a mature B cell leukemia. Otherwise, this has not much of importance. So you see these large cells with, this is the entire thing is a nucleus and a very thin rim of cytoplasm. So this is the typical blast cell, the immature cell. But once I know that there is leukemia, there are several types of leukemia. How do I know which type of leukemia it is? That is where my immunophenotyping and flow cytometry is going to help me. So the flow cytometry, what it does is it evaluates every cell in suspension for the presence of specific antigen. So like we have names, our cells have specific identifiable characters. So you can have a marker X on a B cell. You can have a marker Y on a T cell. So the flow cytometry studies these things and finally gives us a report as to these immature cells. Are they T cells? Are they B cells? Or are they myeloblasts? And are they really immature or they're mature cells? So it gives very, very good information. This is just an example of how you see the common CD antigens in routine practice. So these are all the immature markers. Blastic means immature. So one of them has to be there for me to call it a immature leukemia. The B lymphoid, if you have CD19, 20, CD10, T lymphoid, if you have CD3, CD5, CD7, myeloid, if you have CMPO, CD117, and so on. So now that we have come to the diagnosis, one important thing is also when we do the bone marrow, we have to collect sample for karyotyping and FISH. What is this karyotyping and FISH? So this basically tells us why, how the leukemia started or what was the mutation that caused the leukemia. And this has prognostic information and importance because suppose I have a cytogenetics versus a B cytogenetics, I know how to treat this patient and I know how the patient will respond. I'll come more to it later on. So when we have a child with proven leukemia, my next step is going to be definitive treatment and supportive treatment. They usually go hand in hand. Sometimes we need to give the supportive therapy, stabilize the patient, and then start the definitive therapy. So supportive therapy is very, very important. So these children come quite sick. Like I told you, they have cytopenias, anemia, they may have bleeding manifestation, low platelets. They may come with an active infection. They may come with tumor lysis syndrome when the WBC count is very, very high. or when the WBC count is extremely high, like we saw in the first case where hers was almost 4 lakhs, these cells are really big. They can clog your microvasculature of the brain, of the lungs, of the kidney. So this is called leukostasis. So this is extremely important to manage. It is very important to assess this child for all these problems and start hyperhydration. What is hyperhydration? If at all you're seeing a child with a very, very high WBC count, get a chest X-ray done. Make sure there is no mediastinal mass, because a T cell leukemias can be associated with a big mediastinal mass. And when we start hyperhydrating these children, it can be a problem. So once you make sure that chest X-ray is normal, then start off, establish a IV cannula and give them fluids of at least 3 liter per meter squared per day. And we also start anti-tumor lysis measures with allopurinol and monitor the potassium, calcium, and phosphorus, because these show a lot of variation. And if they are not controlled, and if a good tumor lysis measures are not instituted, your child can have an acute kidney injury.